So water is the immortal fluid or the amrita, nothing other than that. What we have to do? We have to conserve water and see that water is not wasted. That is the basic message of the human body as well as the environment. Okay, let us start with that bigger, larger concept that water is our immortal fluid. Okay, now we'll go ahead with the water balance and polyuria. మధ్యలో ఏమైనా ప్రాంప్టింగ్ క్వశ్చన్స్ వేస్తే చెప్పండి ఎవరెవరు ఓపెన్ చేసి.
Okay, sir.
After a long time, we have meeting again, around 2 weeks gap. And this presentation as usual is available on our website, www.srme.in. So one can go and download that. I'll give you the PDF as well as the video straight away after this lecture. So an algorithmic approach to polyuria and water balance. We just follow a regular pattern without confusing ourselves about this particular issue, and I have written a book chapter also on the same topic in one of the textbooks of medicine on polyuria and water balance. Okay. The body water has got several compartments. It's not that everything is in one container, like you have a water can and water is there and you pour out water into a tumbler and take it. It's not like that. The body water is compartmentalized. So out of a total weight of around 60-65 kilos, 60% is body water. Okay. So 60% of our body weight is water. Why it became like that? Because we are aquatics to start with. We were all living in the ocean and the sea. And then we enclosed some of that water into our body and came out and start living as terrestrials by evolution. So every being is made up of water. The main constituents of you is water. Okay, 65% or 60%. In women it is slightly less because of the fat. In men it is slightly more. Okay. Then this body water of 35 liters is not sitting in one place. It is like, the entire chest is water and rest of it is all other, not like that. So entire abdomen is water, rest of it is not like that. It is distributed all over. It is distributed into 2 compartments. One compartment is called the extracellular compartment. The other compartment is called the intracellular compartment. Itself is nothing but a cytosol. Cytosol is nothing but the cytoplasm combined with all the constituents there and the water. So the cytosolic water is 40%. That's why it's called intracellular water or cytosolic water. Remaining 60% is outside the cells. Outside the cells means, what is outside the cells? Outside the cells we have blood and we have the extravascular space. That is the space between the blood vessels and the blood cell. That is called the extravascular space. In the cell it is the cytoplasm or cytosolic water 40%, and in outside we have the blood vessels and the interstitium or the ECF, extracellular space. Extracellular but extravascular. Extracellular space is called the interstitium, and the blood itself is again made up of formed elements and liquid, and the solid part is the cells and all that you know. The liquid part is the plasma. So it boils down to that out of 35 liters of average water content of the body, 2.5 liters is available as plasma. Around 60% of 35, that is around somewhere around 20 liters is available in the extracellular space and 15 liters is available in the intracellular space. Out of the 20 liters in the extracellular space, only 2.5% is in the plasma. Remaining 90% is in the interstitial space. So if one wants to know the water balance, the water balance is such a way that the proportions of water in the plasma, in the interstitium, in the cytoplasm is kept constant. This is what is called the water equilibrium. And how is this equilibrium maintained? Because of the cells containing a tight cell wall. Okay, the blood vessels containing a layer of barrier which will not allow the water from the blood compartment to easily diffuse. So it is segregated by walls, one in the tubes, the blood vessels, 2 in the cells by the cell walls, and what is left in between is the interstitium. Okay. Now, the permeability of the blood vessel and the permeability of the cell wall is dependent upon several factors. Not that water can freely travel. In some places, yes, it can. In some places, it cannot. So, there are certain restrictions for the movement of water, and a passport is required if the water molecule has to cross from one area into another zone into another zone. So, zone 1, the blood vessel, zone 2, the interstitium, zone 3, the cell cytoplasm. Okay, so understand that is the basic distribution of water there. And now, how much approximately the input of water per day? Around 2.4 liters as water is put in, may vary between environments and people, but up to 3 liters in summertime and less than that in winter time. And some people take more water, some on an average around 2.5 liters, and 1.5 liter is taken as fluid, drunk as liquid. Zero point 0.5 content, zero point 0.5 liters is the content of our food that we eat, different foods. Idli you eat, there is water in that. Dosa you eat, there is water. There is rice you eat, there is water. So every food that you eat contains water. Vegetables particularly, they have lot of water. For example, berekai full of water, anapakai full of water. So like that, watermelon come full of water. So the food that we contain, they differ in their water quantity, and that constitutes around 0.5 liters per day. And the remaining 4 liters, 0.5, 4 liters or 400 ml is by the biological oxidation. What is this? Every molecule of energy that is generated either from carbohydrate or from the fat and rarely from the protein source, the ultimate breakdown product is carbon dioxide and water. And that water is the biological water of oxidation and carbon dioxide. Of course, we have seen in the acid-base balance how it is handled by the lungs. Okay. Now, what is the output? If the water were to be in equilibrium, whatever water I have taken in, almost the same quantity of water should have been put out from the body. And it is put out in the following way. Urine around 1.5 liters, similar to the fluid that we drink. Perspiration around 0.4, that increases in summer, decreases in winter, decreases in fat people, increases in thin people, again slightly variable. And in the breath, lungs are also, they can excrete water because the air that we breathe out contains water. So that is why, when you blow onto a glass in a sort of cold weather, the water vapor in your air condenses and forms a mist-like thing that tells that you are exhaling water too along with your air. That is the loss in the breath, and the fecal loss of water is around 100 ml roughly. Not when there is diarrhea, but when normal fecal loss of water is around 100 ml. These are approximations. Of course, they do vary. So this is what what is called the daily water balance. And then osmolality. Osmolality we know in our acid-base calculations we have done, and sodium is the principal determinant. And how is the osmolality calculated? 2 times sodium plus potassium plus glucose divided by 18 and 1 divided by 2.8 is the calculation. I know sodium is 132, 132 plus 4 is the potassium, 136 in this calculation. 2 times that is the value there, plus 6 is 108 glucose divided by 18, and 1 is around, let's say, 18 divided by, 14 divided by 2.8 is 5, and the plasma osmolarity is 283. This is how we know. But sometimes we, in acid-base calculations, because potassium being small, its contribution being small, we ignore that and only take sodium for our calculations. Nonetheless, this is the actual formula. The same thing holds good for urine osmolarity also, but the constituents there are not much of glucose will be there, but there will be additional bicarbonate will be there. The calculation is slightly different. Okay. Have to understand what is called the hypothalamic pituitary endocrine axis. The master controller, the hypothalamus, gives order to the master, the ringmaster, or the musical orchestra boss. The boss here is the pituitary, and then it gives orders to all the members in the musical concert, the team of the people, the endocrines there. But the master controller who tells the pituitary is, of course, the hypothalamus. Okay, and there is a track between hypothalamus and pituitary, which is called the hypothalamic endocrine axis, and that is important for us to know. So there is what is called the vasopressin, arginine vasopressin. In abbreviation, it is called AVP. If you want to write it as vasopressin, you can write it as vasopressin. Now, vasopressin is basically a pressor. But what is it going to do with the water? You know, it is also called antidiuretic hormone. The other name for that, in fact, the basic function of vasopressin is antidiuresis, and the secondary function is vasopressor activity. The same molecule with a slight alteration in its structure is uterotonic, and it is useful for contraction of the uterus. That is a different story. So as far as medicine is concerned, vasopressin is an antidiuretic hormone and is also a pressor. This is called arginine vasopressin because the amino acid arginine is added to the vasopressin manufactured in the body. That's why it is called the AVP. Synthesized and secreted by what? By the neurohypophysis or the posterior pituitary. Where does the AVP originate? It originates in the neurohypophysis or the posterior. Terminate in the pituitary. This is the hypothalamus and this is the pituitary. And then the nuclei are here and they terminate, the axons are here. The axons are in the pituitary, the chemicals start secreting there, the chemical vasopressin comes and lands up in the posterior pituitary. There is an anterior pituitary here, this is AP, this is posterior pituitary, and it lands up there. That is the vasopressin from hypothalamus to the pituitary. The very important thing, it depends upon the ADH secretion in the plasma, just like the TSH is the one which TSH is the one which adjusts the thyroxine levels in the body. There is what is called a pH, the osmolarity is the one which adjusts it. Normally 285 is the normal plasma osmolarity. At that osmolarity, the amount of ADH present in the circulation is 4 picograms per ml. Okay? Supposing there is the osmolarity is reduced, means what? The body has become the plasma has become dilute. Osmolarity is reduced, that means plasma has become dilute. Then immediately the sensors will tell the body not to secrete the antidiuretic hormone. Antidiuretic hormone secretion falls, there will be diuresis, the fluid is thrown out, and osmolarity is restored back to 285. The other way around, whenever there is an osmolarity is increased, there are osmosensors in the body. These osmosensors are there in the hypothalamus and they stimulate the secretion of ADH. Here, because the plasma is concentrated now, it is on the higher side, then it tells the pituitary to secrete ADH. No, bring ADH quickly and it will stop fluid going from the body. So fluid is retained and this is again brought back to the normal value. Okay, this increase in the osmolarity not only stimulates the ADH but also stimulates the thirst to drink more water. Okay, so this is how you need to understand. So this is a linear curve. A is the threshold for ADH release to start. Below that there is no ADH at all in the body, and B is the threshold for the thirst to start. Okay, so you understand that plasma osmolarity is intricately, nicely, 24 hours into 365 days into 7 is monitored and kept in the small narrow range of 285 milliosmoles by the action of ADH and the stimulation of the thirst center in the posterior, in the hypothalamus, and through that you drink water. Okay, now let's go little further. Now, let us say there is what is called a 2% increase in the osmolarity. That is, the plasma has become more concentrated. There is osmolality has increased, and that not the plasma osmolality, the extracellular fluid osmolality, and that immediately stimulates the CNS osmoreceptors. These osmoreceptors have got two mechanisms. They go to the ADH release from the posterior pituitary or from the hypothalamus to the posterior pituitary, and that ADH induces antidiuresis, that is, water is withheld. When the water is withheld, water is conserved. When the water is conserved, the increase in the osmolality is brought down and circulating volume increases, ECF osmolality is restored. Okay? There is what is called the atrial natriuretic peptide. Atrial natriuretic peptide, it is there in the atria and it also in other tissues. And this ANP goes and tells on enough, there is circulating volume has been restored, osmolarity is coming back, gives a feedback and to the ADH and then controls the ADH. And what is the other channel it goes? The CNS osmoreceptor stimulates the angiotensin 2 mechanism through the renin-angiotensin system. The juxtacolumnar apparatus renin acts on angiotensin 1 becomes 2, and 2 angiotensin then becomes angiotensin 2, are also called the AT2, a potent, powerful molecule in the body, which is a pressor, and also it stimulates the thirst center. AT2's other action is not only vasopressin, vasopressor activity, but stimulating the osmotic receptors there and also into the posterior hypothalamus. The thirst center is stimulated, and then there will be energy to drink water, and that again dilutes the plasma, increases the circulating volume and decreases the osmolality. And this again, this ANP also goes and informs the angiotensin 2. So, just the reverse happen whenever there is a decrease in the circulating volume. That means there is an increase in the plasma osmolality, and there is an increase in the plasma osmolality, osmoreceptors are brought into picture. When there is a decrease in the circulating blood volume, let us say due to dehydration, there are pressure receptors called the baroreceptors. They act on the angiotensin more and less on the ADH. So, in nutshell, either an increase in the plasma osmolality or a decrease in the circulating blood volume, either through the CNS osmoreceptors or through the baroreceptors in the circulation that is there in the vascular tree, and these are stimulated in two channels, one the ADH channel and antidiuresis and water conservation, two the angiotensin channel, thirst and water acquisition. Both are used up to mitigate or offset the increase in the osmolality or a decrease in the circulating volume. This is the water metabolism. Just the opposite. Increase in the circulatory volume. Okay. Now, the Bowman's capsule. Bowman's capsule is a place in your glomerulus. There are what are called the filtration slits are there. You see here the black ones. These are the podocytes, and this is the Bowman's membrane, and these are the endothelial side of this one, and these are the food processes there, and the hair-like things are the glycosal proteins, or the glycosamino-glycogen coating is there. And whenever there is this is the endothelial side and this is the capillary lumen, blood is brought here, the fluid to get into the Bowman's, through the Bowman's capsule, into the tubules. It has to cross the endothelial barrier, cross the Bowman's membrane, and pass through these specialized slits, because the podocytes do not allow the water to come, and this is the Bowman's space or the urinary space, into the urinary space. These openings are under the control of the various hormones that we have discussed, whereas the fenestrations here are in general open. The endothelial fenestrations are in general open, and if there is a disease of the Bowman's membrane, where is the thickening of the basement membrane, then of course that interferes with the transport of water and other chemicals across the the glomerular capsule, right? Bowman's capsule. Now, what are the transport sites in the nephron? If you imagine the nephron like this as a tube, a continuous tube, there are two areas here. This is called the cortex. This is the outer medulla. This is the inner medulla. The cortical part of the kidney, the outer medullary part of the kidney and inner medullary part, they are not simple anatomical distinctions. Physiologically, they are distinct. The cortex is distinct from the outer medulla, which is distinct from the inner medulla. Okay, now there is a filtration of sodium chloride here, and that sodium chloride along with that water also is there, and that water is transported into the outer medulla by aquaporin 1 channels. What are the ACP is aquaporin. A person who discovered these aquaporin channels around 15 years back or around 20 years back is called he is given a Nobel Prize. Till then, no one knew why the water is allowed to move and which controls that. So we were not knowing as students that there were aquaporins. Peter Agre, his name is Peter Agre. He got a Nobel Prize for discovering aquaporin channels, and we have 8 different types of aquaporin channels available in the human body. Most of them are functioning in the kidney, in the GI tract, and other places also. Here, aquaporin 1 is useful for water channels. That is, the aquaporin is like a tube through the cell membrane, and through the tube, just like the coilonge water, no obstruction, straight away through the channel. That is why these are called channels and not gates. This is just goes like that. Water. Then what after coming here, some more water is reabsorbed here in the descending limb of the roof of the Henle or the vasa recti are there, the aquaporin 1, and this is the descending limb of the loop of Henle. This is the loop of Henle, and here remember here this part is watertight. So there is no water exchange in that loop of the Henle. Then comes the ascending limb, and again the solutes are all thrown out, and then sodium, potassium, chloride and all, and ultimately it reaches the distal convoluted tubule. This is the PCT here, and then the DCT here, and then that becomes the collecting duct. And here again in the DCT there are aquaporin channel 2 and 3, which are helpful for water transport into the body, that is to conserve water. And again down the line, this aquaporin 2 and 3 are again in the outer medulla, and 2 and 4 are in the inner medulla. And here remember that the collecting duct aquaporin channels are under the influence of ADH, whereas ADH has got no influence on aquaporin 1 or aquaporin 2. It is the aquaporin 4 channel that is mostly triggered off or opened up by the antidiuretic hormone. So the action of the antidiuretic hormone is basically here. And it is not in the proximal tubule, not in the descending limb, and not in the ascending limb. Okay? Now you see. So this is the collecting duct. We have now come. So here 180 liters is filled per day is filtered. How much amount of fluid is filtered? 180 liters is filtered. What is your blood volume? 5 liters. What is your total body water? 35 liters. In a matter of around few hours, the entire body water can be washed off at that rate of filtration. But luckily, very luckily, 99% of that 180 liters is reabsorbed. 99 liter, out of 180 is around 178 liters is reabsorbed, only around 1 to 2 liters is excreted. This is the tremendous amount of water conservation. This is the amruta. So amruta cannot be wasted. Kidney knows the value of the amruta. So it just conserves the water. 180 liters at an osmolarity of plasma osmolarity of 290 is filtered, and that water contains also sodium there in that, and by the time it reaches the descending limb of the loop of the Henle, 36 liters, that means already 144 liters is absorbed there in the PCT itself by Aquaporin 1, which is not under the control of the ADH. And the loop of the Henle, and then here the ascending limb again, when it comes to here, it is 24 liters here. From here up to here, it is the ascending limb and the distal convoluted tubule and the collecting duct. And the one that is lined up with the green layer there, that is the part which is very amenable for ADH. So the final adjustment of urine, anyway, it is 24 liters here. By the time it comes here, there may be 16 liters or something. And the 16 liters to be reduced to 1 to 2 liters, this final adjustment is done. How much has to go, 1 or 1.2 or 2 or 2.5, is by the collecting duct. Okay? The collecting duct, if you blow it up, zoom it up, it will be looking like this. This is the collecting duct principal cell. We know in the collecting ducts we have the principal cells, we have the intercalcial cells and other things we have seen in the renal tubular acidosis. But here basically these cells have got two parts. One is called the basal part, the other is called the apical part. So the apical part is the basal part of it is on the this is the basal part on this side. This is the apical part, and then there are aquaporin 2 channels here and aquaporin 3 and 4 channels on the other side. So this V2 receptor or the vasopressin receptor is a receptor here which is on the basal side. And these are the channels actually. You can see the tubes like thing. These are the channels. For the channels to be opened, this AVP or arginine vasopressin should come and stimulate this end. Just like you light a firework, the arginine vasopressin receptor is ignited. Rather, the protein comes and tries to sit on the receptor, and the trigger starts. And that trigger progresses as cyclic AMP in the cytosol of the principal cells, and the cyclic AMP triggers the exteriorization of the vesicles. The vesicles contain the channels, and these channels are sitting inside the cell there, and they are moved onto the cell surface, onto the apical side. Channels are placed like tubes. Water can freely enter. Once this is having more water inside, these other channels are available. They will be opening out and then conserving the water. This is how the mechanism. This is the luminal side of the tubule, and this is the basal side where they are attached to the membrane there. So this is the basal side, and that is the apical side of this one. So remember one thing. What is the net outcome? A large volume of water that is filtered is already reabsorbed in the PCT. By the time it comes to the collecting duct, it is hardly around 10% of the total water, and out of the 10%, another 8% is removed. Only 2% is let out, or 1 to 2% is let out in the urine. For that, the collecting duct acts, and the collecting duct is under the influence of arginine vasopressin, which is called the V2 receptor. There are diseases. Why do you want to know all these things? Because there are diseases which have got where there is a mutation of the V2 receptor, where the arginine vasopressin will not be able to work normally on the receptor. Okay. So the V2 receptor is triggered there by the AV in the cytosol of the principal cell, which activates the vesicles. These vesicles are they are internalized to start with. They are moved on to the apical side of the membrane there, and apical side the channels are placed through the tube. Water freely enters, and the entered water is again taken into the body through the free ACP3 and ACP4. Here it is ACP1. ACP1 is not under the control of the antidiuretic hormone, whereas the ones in the collecting duct are under the control of the antidiuretic hormone. This is the story as far as the collecting duct is concerned. See how much amount of effort is being done without your knowledge. Every day, every minute, every second, the kidney is conserving water, the amrita. So we are also reminded of the Kidney, when we look at it, we have to also conserve water, not waste water in any manner that we can think of. Okay. So the renal excretion of water, the glomerular filtration is 120 ml of water per minute. You know the GFR, glomerular filtration is 120, 60 minutes in in an hour, and 24 hours is 170 to 180 liters is what is filtered. The final urine is only 1 to 1.5 to 2.5 liters per day, depending on the environment and various other conditions. So 99% of the filtered water is reabsorbed, only 1% is finally excreted. 70% of the water reabsorption occurs in the PCT through the Aquaporin 1, which are not under the control of ADH, not ADH mediated. Rest 29% is by Aquaporin 2, 3 and 4, and these are under the control of the ADH, okay, particularly Aquaporin. Resorption of water in the collecting duct, of course, is ADH mediated. So this is the, in nutshell, we understood. So we understood hypothalamic pituitary axis. We understood what triggers the mechanisms like, increase in the extracellular fluid or decrease in extracellular fluid osmolarity or decrease in the blood volume, stimulates through the ADH system and through the angiotensin system also. And we also understood the renal handling of water, and majority of that is absorbed in the proximal convoluted tubule, 70%. Only 99% is reabsorbed, 1% is excreted. The final part of adjustment is done in the collecting duct under the influence of aquaporin mediated reabsorption, which are under the control of the ADH. Okay. Sink into those ideas. Just what is happening, visualize in your mind how the water is being regulated. Everything looks very simple. We take water, we pass urine, we are happy. We don't know what is happening in the body. There are so many things that are going on in the body. So a decrease in the plasma volume, a decrease in the extracellular fluid volume, a decrease in the extracellular fluid volume, there is a stimulation of the renin. We know that the baroreceptors are stimulated. That produces angiotensin formation. Angiotensin is a dipsinogen. That is, dipsinogen means it stimulates thirst. It's a dipsinogen, and it also promotes AVP release to conserve water. That is one stimulus. What is the biggest stimulus for that? Decrease in the intracellular circulating, intravascular circulating volume. The other is increase in the extracellular fluid osmolarity. This is the intravascular fluid. Okay, decrease in the intravascular fluid, baroreceptors, and the increase in the osmolarity in the ECF by the Osmo receptors are stimulated here, and AVP is released. AVP leads to less urine antidiuresis, and without AVP, we will have what is called water diuresis. That is why whenever there is a defect in the AVP or any pathways related to that, we have polyuria, and that is called diabetes insipidus. Okay, we come to that. Okay. Water balance, complex interaction between the plasma osmolality, plasma volume, thirst center, kidney, and the posterior pituitary, and the hypothalamus, and the ECF osmolality also. Not only the plasma, the ECF osmolality is also important. These are the various ones. Dysfunction in any of these areas results in polyuria and polydipsia. Now, what are the diseases under which we have difficulty in the water balance? One is a cardiac failure. We know the patient retains water, is waterlogged, there is JVP raise, there is pedal edema, there is ascites, there is hepatomegaly. All these are congestive features because of retention of water along with that sodium. Sodium and water are retained in cardiac failure, and there is a disorder of water balance actually. Secondary to the heart failure. Cirrhosis of liver, again, liver we know the causes of edema or water stagnation in the body. One is cardiac failure, second one is cirrhosis, third one is renal failure, and hyper and hypothyroidism also can affect the water balance. Addison's disease because of the absence or decrease in the water retaining hormones, the cortisol hormones and the mineralocorticoids are there. And central diabetes insipidus, CDI, nephrogenic diabetes insipidus, psychogenic polydipsia. This is called the PPD or compulsive water drinking, CWD, and pregnancy. So what are the diseases of water balance? In nutshell, heart failure, liver failure, renal failure, hypothyroidism, Addison's disease, and below that are all the diabetes insipidus, central diabetes insipidus, nephrogenic diabetes insipidus, psychogenic polydipsia, and pregnancy. We need to differentiate these various types before we understand how to treat them. Okay. Now the question is, what is polyuria? Patient will come with symptoms, sir, I am having more urine. I am passing more urine. The common thing is, I may be having diabetes, check for diabetes. Not there. Then what else? That is where exactly is the diagnosis of polyuria comes. Okay. What is polyuria? By definition, passage of excessive quantity of urine. Then what is excessive quantity? Urine of more than 40 ml per kilogram per day. Okay. That is a 70 kilogram person into 40 ml, 2.8 liters, roughly more than 3 liters. Okay. Any urine output at least more than 3 liters or 2.5 to 3 liters a day, you should think of polyuria. Polyuria implies either water is lost or water is going like a friend along with the solute. What is the commonest solute which takes water along with that? Glucose. So somebody is having hypercalcemia, glucose is going in the urine, and it will say, నాకు చాలా భయంగా ఉంది, నేను ఒక్కడిని వెళ్ళలేని, ఎవరైనా రాడే కూడా అంటే వాటర్ ఆల్సో దాంతో వెళ్ళిపోతుంది. So wherever Rama goes, Sita accompanies. Wherever glucose goes into the urine, the water accompanies. So this is what is called solute diuresis. Either the glucose or any other solutes, calcium for that matter. So if there is hypercalciuria, then there will be polyuria. So like that, any solute will trigger water to go along with that. That is solute diuresis. Independently, when there is no solute diuresis, simple water alone is going. That is non-solute diuresis. That is called polyuria without the solute there. It could be a solute diuresis or it could be a simple water diuresis. So what is the definition of polyuria? Anything more than 40 ml per kilogram body weight is polyuria. In summer and winter there will be a difference. In summer there will be less urine, in winter there will be more urine, because in summer the perspiration is more and loss through the skin is more, and then in winter the loss through the kidney is more. Exercise, stress, winter, all would probably have an impact or bearing on the amount of urine that is sent out. During exercise, a lot of perspiration occurs. During stress also, a lot of perspiration occurs. Urine output decreases. In summer also, urine output decreases. So the urine volume will be lesser. Polyuria is usually associated with polydipsia. What is polydipsia? That is, they need to take water again and again. Normally we drink around 4 or 5 times a day or during the meal time, and in between probably 1 or 2 times and at night time. But the people here, they need to drink every day, every hour, every 2 hours. They need to drink water. They have to carry a sort of a tank with them and keep on drinking from that. Okay, that is what is called the polydipsia. Polydipsia or PD. When do you say there is polydipsia? When the water intake is more than 100 ml per kilogram per day. 60 kilograms, 6 liters. So somebody is drinking 6 liters or more fluid per day. You can say there is polydipsia. So remember these two definitions: polyuria, more than 3 liters per day; polydipsia, more than 6 liters per day, is polydipsia. The frequency of urine is, people will usually complain, sir, I'm having frequency of urine. Mathematical urine. That is different. Frequency of urine is small amount of urine, each time passes 10 ml, 15 ml, like that 20 times he goes or 30 times he goes, in an hour 3 times he goes. Means what? He has got some urinary infection. There is a prostate, there is an obstruction, there is a stone disease, there is an infection, and you have to look for that. Frequency is not polyuria. Frequency coupled with quantity is polyuria. What are the major causes of frequency? urinary tract infections, stone diseases, benign prostatic hypertrophy, urinary incontinence itself. Normally we hold around 150 to 200 ml very easily, maybe up to 300 ml. But during incontinence, people, they will not be able to hold more than 20-30 ml. The moment 30 ml is there, the trigone is stimulated and the urine incontinence will be there. So frequency can be urinary tract infections. So there will be a short notes on what are the discussed frequency of urine. Means urinary tract infections, stone disease, and then the BPH, urinary incontinence, and diabetes also. Not only the number of times, the quantity also is more because of the solute diuresis. Okay, so these are various causes of frequency and polyuria. How does polyuria occur? Four mechanisms. Let's say somebody takes more water. Obviously, he has to go more number of times. He has to pass urine and large quantity of urine. That is increase in the intake of the fluids. This happens, sometimes you say, drink more water, drink more water. This is very important for you. Particularly, whenever a fever patient comes or anybody, you start telling him, no, you have to drink a lot of fluids. They go on drinking. Of course, not other drinks, but water. And then what happens? Psychogen, it could be lead to a little bit of polyuria. Psychogenic, drinking on their own, they may be psychologically, they may be stimulated to drink more water. They will have stress, anxiety, psychogenic polydipsia. Or there is an increase in the glomerular filtration rate. That means instead of normal being 120 ml, the GFR is increased. Metabolism itself is heightened. How? By hypermetabolic states, hyperthyroidism, fever, or any of those things. This is called increased GFR. Or there is an increase in the output of solutes, which are asking the water to accompany the solute. As a sort of as a friend. So whenever there were more hyperglycemia is there, glycosuria is there, water also goes along with that. So that is diabetes mellitus, hyperthyroidism, hyperparathyroidism with hypercalcemia, or you have given him drugs like diuretics which increase the solute in the DCT. By promoting solute washout, they also have water washout. And inability of the kidney to reabsorb water in the DCT, which is of course the context of today's discussion. That is the CDI, central diabetes insipidus, nephrogenic diabetes insipidus, drug-induced diabetes insipidus, and chronic renal failure. These are the various mechanisms or causes of polyuria. Increased intake of fluids, psychogenic polydipsia and polyuria, stress, anxiety. Increased GFR, hypermetabolic states, fever, hyperthyroidism. Increased output of solutes, as in case of diabetes, hyperthyroidism, and hyperparathyroidism with calciuria, or use of diuretics. Or inability of the kidney to reabsorb water because in the collecting duct, and that is because of the CDI or NDI or drugs or CRF. Now, is it increased volume or increased frequency? First question. We said we promised that is going to be an algorithmic approach. So what we do is in the history, we wanted to decipher whether it is a volume increase or a frequency increase. That you can easily find out by asking the patient how many times you urinate and each time you pass large quantity or small quantity. Is there associated polydipsia? That's another important question. Immediately you need to ask. Or of course, is it associated with thirst also very much? Is there weight loss as occurs in underlying malignancy and diabetes? Is there family history? Certainly diabetes insipidus and diabetes mellitus particularly runs in families. We know it's a familial disease, and past history, any neurosurgery is there, any meningitis, any head injury, any psychiatric illness, compulsive water drinking. So in the history, is it frequency? Is it increased volume? Is it associated polydipsia? Is there weight loss? What is the family history? Is there, my father also used to have sir like this, my mother also. So that puts in a different disease altogether. And then past history of neurosurgery, meningitis, injury, and psychiatric illnesses, compulsive water drinking, CWD, drugs like diuretics, lithium, analgesic abuse, vitamin D excess, hypercalcemia, nephrotoxic drugs. Recurrent infections can also trigger both frequency and volume, particularly in patients with diabetes. And history of hypertension, which can lead to CKD or hypercalcemia or urinary tract outflow obstruction, UTO, urinary tract outflow obstruction. And then PKD, polycystic kidney disease, are some of the causes of polyuria. So we need to, in the history, we have to elicit these important aspects. Okay. Now, when I come to the physical examination, what do I see? I just uh, when you examine them, wasting and cachexia, diabetes mellitus, diabetes insipidus, and malignancy. These are the things that you have to look for. Is there cachexia? Is there wasting? So obviously underlying diabetes insipidus, diabetes mellitus or malignancy skin manifestations, particularly in cases of cancer and diabetes, there may be associated skin changes, nail changes in case of chronic diseases, clubbing of the nails, CKD nails, carcinoma of the bronchus may have clubbing, anemia associated, think of malignancy and CKD, lymphadenopathy associated, infiltrative diseases, malignancy, fundus examination for papilledema, for hypertensive and diabetic retinopathy changes. So, wasting, cachexia, skin manifestations, nails, anemia, lymphadenopathy, fundus are some other physical points which we need to check. Then, how do I classify polyuria? Endocrine causes, renal causes, iatrogenic causes, metabolic causes, psychological causes, and psychogenic causes, and other causes. Okay, what are the endocrine causes? Diabetes mellitus, compulsive water drinking, central diabetes insipidus, and then Cushing syndrome. Renal, chronic renal failure, UT obstruction, that is after relief of the urinary tract obstruction, chronic pyelonephritis, nephrogenic diabetes insipidus, Fanconi syndrome, along with other defects in the proximal tubule. There could be a defect of water reabsorption also. Iatrogenic, diuretic therapy, alcohol, lithium, tetracyclines. Metabolic, hypercalcemia, potassium depletion. Psychological, PPD, and compulsive water drinking. That is psychogenic polydipsia, PPD, and compulsive water drinking is CWD. Other causes, sickle cell anemia, and then the venous thrombosis, PSVT, systemic venous thrombosis. It can also produce. Diabetes insipidus. Now we come to an area what is called the diabetes insipidus. The less talked about disease, but very important for you to understand diabetes insipidus. Diabetes insipidus refers to an abnormal state of water and non-osmotic diuresis. It's not due to the solute, it's not osmotic diuresis. DI can be early sign of serious underlying disease, a brain tumor. They can present with DI, ultimately by evaluation you may find out that it is due to a brain tumor. Abrupt onset of polyuria and preference for extremely cold and iced water suggests central diabetes insipidus. So they'll have preference for always they want to drink more iced water, cold water. They don't want to drink normal water, and there will be abrupt onset of polyuria. Diagnosis of DI is missed sometimes for years, and DI has got 4 major types. So when I say DI or diabetes insipidus, CDI, central diabetes, NDI, nephrogenic diabetes, PPDI, this is the psychogenic polydipsia syndrome, this is called the PDDI, that is psychogenic polydipsia with diabetes insipidus, and then the GDI, gestational diabetes insipidus. Gestational diabetes insipidus. Why it is called insipidus? What is insipid? Insipid means lethargic. Lethargic. What is lethargic? The antidiuretic hormone. Either it's lethargic or it is not there. So the ADH activity is lethargy. That is why it is called insipidus. It is not sweet. That's why it is not diabetes mellitus. Mellitus is honey. It is not sweet urine. It is rather non-sweet diabetes, which is the lethargy of the body, of the ADH part of the control. Okay. Now, So we said there are four types: CDI, NDI, primary polydipsic diabetes insipidus, or the psychogenic polydipsia, PPDI, and the gestational diabetes. So central diabetes insipidus, generally it is neurogenic and decrease of the ADH or ABP. That means the release of the ADH or the arginine vasopressin is at fault from the neurohypophysis and the posterior pituitary. Nephrogenic diabetes insipidus, the ADH secretion is perfect, but the target organ, the collecting duct, the aquaporin channels there, the vasopressin receptor is not responsive to the ADH. Okay? Central is directly from the posterior pituitary or the hypothalamic neurological neurogenic disorder wherein there is a decrease in the ADH or the AVP. The nephrogenic, the secretion of ADH is normal, but then the target organ is not responding and opening the aquaporin channels to conduct to bring back the water into the system. So much of more water is left in the tubular lumen, and so much of polyuria. So primary polydipsic diabetes insipidus, the people will drink more water compulsively, and this reflexly suppresses the ADH. The pituitary is normal, but the excess of water, there will be hypervolemia. The excess water reflexly suppresses ADH, and that produces, and there will be dipsinogenic and psychogenic. Two types are there: dipsinogenic type of primary polydipsia or psychogenic type, or iatrogenic. Drink more water, drink more water. That advice, iatrogenic. Or you push more fluids through the vein than what is required. Ultimately, they have to throw it in the urine. So that is excessive water input into the body. Either iatrogenic, dipsinogenic, psychogenic, primary polydipsic diabetes insipidus. It is not the ADH is at fault, nor the kidney at fault, but there is excess of fluid thrown into the system, which secondarily suppresses the ADH, and so there is polyuria. Okay? Central diabetes insipidus, decrease in the ADH or AVP secreted from the neurohypophysis or the hypothalamus, neurogenic. Nephrogenic diabetes insipidus, here there is no defect in the secretion of AVP, but the kidney is not responding, the collecting duct is not opening the aquaporin channels, either due to a mutation of the vasopressin receptor or due to the resistance of the vasopressin is resistant, not able to open the receptor. The key is not functioning properly. Okay, there are kidney diseases which are interfering with the receptor activity there. And primary polydipsic, there is neither a fault of the pituitary or the neurohypophysis, that is the hypothalamus, nor there is a fault of the kidney, both are normal, but excess water is thrown into the system by compulsive drinking, dipsinogenic or psychogenic or iatrogenic, and that excess water is suppressing the ADH. So there is excess fluid going in as urine. The last one is gestagenic. What is this? Gestagenic means not gestational. Gestagenic during pregnancy due to ADH destruction by the vasopressinases of the placenta. The placenta has got an enzyme called the vasopressinase. This vasopressin destroys the vasopressin that is secreted by the pituitary, and ADH is metabolized due to inactive thing by the vasopressinase. So much so, there is a relative deficiency of ADH, and there will be gestagenic diabetes insipidus. It's a very important point to know. And always, when a pregnant woman comes with polyuria, the first thing we think is she a diabetic, gestational diabetes? It could be gestational diabetes insipidus also, because of the vasopressin being responsible to reduce or destroy the ADH. Now we go to each one of those entities. Neurogenic, nephrogenic, PPDI, and gestagenic. Neurogenic, acquired, and majority of the reasons are acquired. In the neurogenic, majority or causes are acquired. 95%. Only 5% are inherited. Okay? What are the acquired lesions? It could be a tumor, it could be trauma, it could be infection, it could be autoimmune. Just like any other brain conditions. Okay? Immunity, autoimmunity, granulomatous diseases like tuberculosis or any other granulomas, this one, meningitis, encephalitis, head trauma, brain tumors of various nature. And what will be the investigation? Of course, you have to evaluate the CNS by MRI, CSF examination, and all that. So 95% of the cases of central diabetes insipidus are neurogenic or acquired, whereas only 5% are inherited due to mutations of the vasopressin gene, autosomal dominant or recessive or X-linked. All the three, AD, AR, XR, vasopressin gene mutation, which is an inherited defect causing central diabetes insipidus. In that, the ADH secretion is at fault from the central posterior hypophysis or hypothalamus because there is a genetic mutation. And beyond all that, there is a few type cases which are idiopathic. Okay, let's say these are 90%, idiopathic becomes 5%. So that is how the distribution. So whenever we see a central diabetes insipidus, our focus is on evaluating the brain and not on the genetics, not very rarely genetic. So now let's go to the next one. So lack of AVP production or secretion, central diabetes insipidus is the hallmark is AVP is secreted, not produced much, or maybe partial or complete. Urine volume is very high, 8 liters or 10 liters. What is the bladder capacity? 250 ml. So each liter requires 4 urinations, 10 liters require 40 urinations. 40 urinations in 24 hours is every half hour patient has to visit the bathroom. It's very cumbersome. Imagine throw 250 ml of urine. Really miserable. Really miserable. So that is the amount of volume of urine that they have. Whereas in nephrogenic and all, the volume will be more than 3 liters, but not 10 liters or 8 liters or 15 liters. Polydipsia is usually a feature because of such an amount of tremendous amount of water loss. Thirst centers are stimulated and very troublesome. They keep on drinking water every 15 minutes, and if they don't find water, they feel really crazy. So that's very important disease, central diabetes insipidus. Any disturbance or injury of the hypothalamus and pituitary is a potential cause. We know that it could be trauma, it could be neoplasia, it could be inflammation, it could be granuloma, it could be injury, it could be cyst or idiopathic. So the features are AVP production is decreased or absent or reduced very much, or AVP secretion is decreased. Urine volume is very high. Secondary polydipsia is the rule. Diseases of the hypothalamus and pituitary, mostly neurological, 95% are acquired, only 5% are genetic, and sometimes idiopathic. Then this is what is called the AVP receptor protein, also called the V2 receptor protein. So this V2 receptor protein this is the extracellular space, and this is the intracellular space on the basal side, not on the apical side. Here it has got an NH2 terminal there, and the protein is folded in such a way, the arginine vasopressin receptor protein is folded in such a way so that there will be some openings in that, and the AVP can come and stimulate the receptor protein. It ignites here, and then that enters into this is the COOH here, and that is the NH2 terminal there. Please close your mic. Now, this is the AVP receptor protein, and there could be a misfolding of the protein there in the AVP receptor, so that the arginine vasopressin, when it comes, it's not recognized by the receptor. Okay? That's how it happens. So nephrogenic diabetes insipidus, here the reverse. Most 90% are congenital, only 10% are acquired. There it is 90% acquired and only 5% are genetic. V2 vasopressin receptor mutations, 180 mutations are documented. and chromosome XQ28 is the seed there, and there is a protein misfolding as a V2 receptor, not translocated, not translocated to the basolateral membrane of the collecting. What happens? Then, because of the misrepresentation or misfolding, the receptor is not thrown onto the basal side, basolateral membrane. The receptor is not available for the V2 to the vasopressin to come and interact. The protein is folded inward and it is not showing the receptor outside. This is called the non-translocation of the receptor. 90% of the NDI is genetic. As I told you, 10% is acquired. Just like there are 180 types of mutations, the chromosome XQ28 is involved, V2 receptor misfolding, that results in non-translocation of the receptor onto the basolateral membrane. 90% of the NDI is genetic and 10% only is acquired. Acquired NDI, what are the causes of acquired NDI? Hypercalcemia and hypokalemia, low potassium, high calcium, will produce polyuria through the acquired NDI. Bilateral urinary tract obstruction, lithium therapy, ARF, advanced CRF. Polyuria of acquired NDI is of a moderate degree, only 3 to 4 liters. Normal being less than 3 liters, these will have 3 to 4 liters. Not very much. Whereas the genetic NDI, it will be around 6-7 liters. Whereas in the CDI, it will be more than 8 or 10 liters. So depending on the quantity of the urine, you can roughly get an idea whether it is a CDI or a genetic NDI or an acquired NDI. Okay? Now, nephrogenic diabetes insipidus commonly occurs at birth because it is genetic 90%, urinary frequency, nocturia, enuresis, and frequent and constant thirst. The baby cannot tell, and then there will be the mother has to change the diapers so many times, and the baby wants the breast every 15 minutes or half an hour because of the thirst. And thirst and polyuria cannot be verbalized by the patient. Inconsolable crying and usually wet diapers. Because of frequent urination, diapers are wet. Baby is crying, 1 for the thirst, 2 for the wetness of the diapers, and frequent need to nurse the baby. Skin of the baby is very dry. Very cold extremities because peripheral circulation is shut down and failure to thrive. These are some of the important features of children with genetic type of NDI, and that is the common type. And then we have the polydipsic DI. Polydipsic DI is acquired type because neither the secretion is at fault from the pituitary nor the receptor and the kidney are at fault. It is more that more water is taken in. And so secondarily ADH is suppressed. It is acquired, idiopathic mostly, chronic meningitis, granulomatous diseases, and then multiple sclerosis and others, and pathology of the brain. And psychiatric illnesses like compulsive water drinking or primary polydipsic water. And gestagenic, we know it is due to the vasopressinases, and it is short-lived. It happens in the first trimester. And once the pregnancy advances, these vasopressin secretions are reduced, and they will come out of the problem. Not like diabetes mellitus following the gestational diabetes. So polydipsic type of diabetes insipidus, mostly acquired. Sometimes it is iatrogenic also, dipsogenic. And then how do I go about? You have to have, first question is it more than 40 ml per kilogram body weight? To know that, we have to have a 24-hour urine collection. So 24-hour urine collection means we have to have 5 liters of plastic cans, not 1 liter bottles. If you give 1 liter bottle, you will come out with 5 bottles you have to bring. Very inconvenient. So give them 5 liter containers with 10 ml of acetic acid during the normal fluid and food intake. No restriction of food, no restriction of fluid. Give him a container of 5 liter plastic container with 10 ml of urine. 10 ml of acetic acid. Now, how do you do that? The moment he gets up on the day of test, he will pass all the urine, not included in the bottle. He'll just pass in the toilet. And from then onwards, he starts collecting everything. And next morning, early morning urine, after getting up, he will include it. That means he has included overnight urine of that day, plus the whole day's urine, and not the previous night's urine. That is the instruction. So you empty the bladder. Don't pass that urine into the bottle, into the can or container, And then from then onwards, whatever urine you get, keep on collecting in the container. So he has to keep the container near his washroom. Otherwise, he'll forget. So he'll forget to collect it and will not get a proper measure. And the next morning, he gets up, it must be included. That becomes 24-hour urine. Fluid intake is normal, normal exercise, normal food intake. Now, by definition, more than 40 ml per kilogram body weight is polyuria. Then we have to look at the osmolality of the urine. If the osmolality is at less than 300 or it's more than 300. Why? If the solute diuresis, the osmolality will be more. So we have large urine with solute, conditions are different. We have our diabetes, hypercalcemia and renal failure and all those things. So we need to measure the urine osmolarity. And also urine specific gravity is a vague measure. Urine osmolarity is a better measure. Polydipsia also can be assessed by asking him to register how much amount of fluid he is drinking, and if it is more than 6 liters per day or 100 ml per kilogram body weight, then there is polydipsia also. And measure the plasma sodium on that day. These are the things that you require. What are the things? 5-liter container with 10 ml of acetic acid, and then he has to faithfully collect 24-hour collection, exclude that day's morning urine, include next morning's urine, and then quantity to be measured, urine osmolality of the 24 hours to be measured, and then polydipsia can be identified by have a diary of the water intake or any fluid intake and measurement of the plasma. Okay, here you have an idea of what are all the causes and the water metabolism control, and then the central diabetes insipidus, nephrogenic diabetes insipidus, PPDI, and gestational diabetes insipidus, and how to go about stepwise we will see in the next class.